Okay, our third speaker, Scott Roberts, is an associate professor of health behavior and health education at the University of Michigan School of Public Health. He obtained his bachelor's in English from Duke, his PhD in clinical psychology from the University of Michigan, with a specialization in geropsychology. He went on to serve as an assistant professor in the Department of Neurology at the Boston University School of Medicine, where he was a co-director of the Education Corps in their NIH-funded Alzheimer's Disease Center. In 2006, Professor Roberts returned to the University of Michigan, where he currently teaches in the School of Public Health Genetics program and leads the Genomics program within the Center for Bioethics and Social Sciences in Medicine. He's also a co-director of a new dual master's degree program in public health and genetic counseling. Dr. Roberts conducts research on the development and evaluation of genetic risk assessment programs for adult-onset diseases. Through a series of clinical trials offering genetic testing for the risk of Alzheimer's disease, he is focused on participants' motivations and interests in genetic testing, the psychological impact of providing risk disclosure, and behavior changes prompted by risk assessment. He's recently completed a study examining disclosure of genetic research results to participants in a large genetic epidemiology study of melanoma risk factors, and is the PI of an NIH-funded planning grant to develop and evaluate a program that introduces genetic susceptibility testing for 5 common diseases into primary care. Professor Roberts, thank you for joining us.
It's great to be back in Rackham Auditorium, site of my dissertation defense many years ago. Not this auditorium, but this building. I'm going to talk today about some issues that aren't directly related to dentistry. As you heard, Alzheimer's and cancer aren't necessarily disorders you guys deal with on a day-to-day basis, but hopefully some of the topics that we've looked at in other disease contexts, you can imagine how some of the lessons we've learned might be relevant to your field. So I want to start here by talking about my daughter in a very quick way. First of all, this is a way to show how Dr. Deborah Lissel has been a big part of our lives. She's a U of M alum, so I wanted to recognize her. But my daughter is 8 years old, so I think she represents this idea of technologies that we're developing today might be applicable to a patient like her somewhere in the future. I think you're hearing that a lot of the stuff that's being developed in your field is not necessarily ready for prime time, but I think if we take this future-looking approach, we can think about preparing ourselves for a day where we might be able to incorporate some of these different technologies. And so I think Ella represents this idea of the future dental patient. So I'm going to talk today and try to give you guys an overview of genetic testing and its potential relevance for dental medicine. I'm going to talk about social and behavioral research we've conducted in the context of ApoE testing for risk of Alzheimer's disease, because we've looked at issues that I think would be relevant if this technology is to be incorporated in your world. The idea of how do you estimate risk? How do you communicate about risk to patients? How do you understand how patients might respond to that information, both behaviorally and psychologically? So those are themes that we've looked at in our studies. And then finally, I'll be talking about some of these broader ethical and policy implications when you think about introducing genomic information both into healthcare and then also into broader society. I think we're seeing increased access to genomic information. I think Dr. Ginobili pointed out this idea of direct-to-consumer genomic testing coming on the marketplace in the last few years. So I think the reason why many of us may be here today is because we're fascinated both at a scientific and social level by this idea of genomics in a lot of ways. And so we've seen in the scientific community, you see the Science magazine article about, breakthrough of the year was the field of human genetic variation just a few years back. The business world, you see the cover of Forbes magazine looking at cancer genetic testing, covers of Time magazine, Wired magazine. So there's a lot of fascination out there about what our DNA might say about ourselves and our future health risks. And I think what we've seen this kind of fascination reflected as well in terms of scientific progress. So this is a site known as genetest.org that I think shows how you've seen the proliferation of genetic tests for a whole host of disease over the past 15 years or so. And there's actually, for those of you who are interested, the NIH just this year has developed its new genetic test registry, where it's a comprehensive catalog of genetic testing throughout medicine. So you might check out that resource if you have interest in how genetic testing is being applied throughout the field of medicine. And I think the fact that we can even talk about this being a technology that might be used in the relatively near future relates to the idea of the rapid progress in terms of being able to do this kind of work at ever lower cost. So you see here a schematic that the NHGRI has put out that shows the cost of sequencing an individual genome has plunged dramatically in recent years. And you may have heard of this development of so-called next-generation sequencing. So we see that this kind of technology is something that used to be prohibitively expensive, but we're now at the point where we can sequence an entire human genome for around $1,000, which is something that was thought to be perhaps a pipe dream even just a few years ago. So I think that's something that puts this technology within reach. But again, the question is, just because we can do it, should we? And what are we going to do with all this kind of information that we're still trying to sort out and get a sense of what it truly means? Now, I think we're still in the early days of applications in dentistry, but I hope people got a chance to look at this recent medical review from a group at Duke that is one of the leaders in the field of both genomic sciences and policy. So they have a very insightful review in terms of how might this field be applied moving forward. And you can see just to some of the examples here, whether it's dentists might be involved in, for example, identification of oral cancers, looking at risk factors for various problems. I think you can see that there are some applications that, again, are not commonplace right now, but the field is trying to move toward. So what I'm going to do is talk about how do we apply genetic test information, from how do we communicate about what it means. And of course, there's a lot of different types of genetic tests out there that are used for various purposes. A lot of these are probably familiar to you. I think we'll see perhaps the most activity around the area of pharmacogenomics. That's certainly an area where we're seeing a lot of investment in terms of trying to develop genetic tests that can help predict response to various medications, whether it's predicting the efficacy of response, whether it's predicting side effect profiles, so to know who should stay away from certain drugs, I think. And we already see this with very commonly used medications like Plavix and warfarin. The one area that I've done most of my work in is around this idea of susceptibility testing. So using genetic testing to give a sense of one's risk of a future health condition. And again, I think this is another area where we might see applications in dental medicine as well, where we might be able to use genetic testing to give a sense of higher or lower risk populations for various problems. And I use the example of Alzheimer's disease. So just to give you a very quick overview of risk and protective factors for Alzheimer's disease, I don't expect you to memorize all of these. The idea is really just to show that this is, like many other common health conditions, a complex disorder, where there's a whole host of risk and protective factors that we need to reckon with. But it also happens that genetics is an important piece of the puzzle here. So even though it's not the entire picture, genetic testing can still be very valuable in terms of trying to identify who might be at risk for a condition like Alzheimer's. And what we learned in the 1990s was that in some families you actually see these mutations present that are inherited in an autosomal dominant manner, so that if you have a parent with these rare types of Alzheimer's, you might be at 50% risk of developing the disorder yourself, and often much earlier age of onset than we typically see in Alzheimer's, so even in one's 30s or 40s. So these mutations that were identified on chromosomes 1, 14, and 21 in the 90s can be used in clinical practice today for the families that are affected by this particular type of familial Alzheimer's. Now, of course, most cases of Alzheimer's don't involve these mutations, so I think only about 1 or 2% do. But the findings were very valuable, for example, in developing animal models of the disease that are used today to try to develop new treatments. But from my perspective, what's more interesting from a public health perspective is the genetic polymorphism known as ApoE that some of you may have heard about. So ApoE is a gene that's found on chromosome 19 where certain variants confer risk of Alzheimer's disease. And the E4 allele in particular is the allele that is associated with higher risk of Alzheimer's disease. And from a public health perspective, it's important to think about because we see that approximately 1/4 of the general population carries an E4 allele. So many of you in this room probably are E4 carriers. And so it's much different than a case like Huntington's disease, for example, where it's very rare that people in the general population have these mutations. So we've looked at ApoE testing in a variety of studies and trying to figure out how can we use something like ApoE testing to help us understand how to communicate about genetic risk and how people respond to risk information. So we've done a series of studies. I think it's an unofficial NIH rule that you have to have an acronym if you do a clinical trial. So we tried to come up with an acronym that actually says something about our studies. So it's known as REVEAL, Risk Evaluation and Education for Alzheimer's Disease. And my mentor, Bob Green at Harvard, is the overall PI. So it's a series of intervention trials where we've looked at providing ApoE testing primarily to people with a parent or sibling with the disease, so first-degree relatives of people with Alzheimer's. And we've looked at trying to provide a sense of what's the impact of delivering this information. So we've completed 3 trials to date, and each one has built upon the previous trial. So we started by looking just at the basic question of what's the psychological and behavioral impact of getting ApoE information. So in that trial, one group got risk information that incorporated ApoE, and the other group, the control arm, also got risk information, but it did not incorporate ApoE testing. Then in our second trial, everybody got ApoE testing as part of their risk assessment, but we tried to do this in a briefer format than we see in traditional genetic counseling. Because one thing that I think dentists are going to have to be occupied with is, can they educate about genetic information without having to refer to a specialist all the time? Because we know that genetic counselors who are superb at what they do, but they're relatively small in number and they have very time-intensive protocols. So we need to think about, can we deliver this information in a more streamlined manner? So that's what our second trial looked at. And we also added Howard University as a site to try to look at some issues around African Americans versus white patient views on this topic. And then most recently, we've looked at this idea of pleiotropy in genetic testing. Pleiotropy refers to the idea that a genetic factor could be something that puts you at risk or is protective not just for one disease but many diseases at once. And ApoE is a case in point where the E4 allele, for example, is not just a risk factor for Alzheimer's but other conditions as well. And then we also threw in a telephone versus in-person disclosure to look at, do people always need to receive this information in person? Can we do this by telephone with similar results? So over the years, we've done these trials at various sites. I'm the site PAI at Michigan. Our current trial is a 4-site trial looking at patients at Harvard, Howard, Michigan, and Penn. I mentioned that we rely heavily on genetic counselors to deliver these protocols. Over the years, we've seen about 700 people who have a family history of Alzheimer's disease. They've tended to be, the mean age tends to be people in their 40s and 50s, although it ranges from early 20s to late 80s. And in each of our studies, we've followed people for a year after receiving the information to determine the impact. So let me just give you this flow chart. So, and this is kind of a similar protocol we've used in all of our trials. So we enroll eligible people. We provide a formal education session where we explain what's involved in genetic testing for this type of condition and with this particular test. If people are interested, we then do a blood draw, not a saliva sample, unfortunately, but a blood draw that we send to Athena Neurosciences, who owns the patent on ApoE testing. And in our first trial, like I mentioned, we randomized one group to get risk disclosure information that incorporated ApoE. The control arm got a more general risk assessment that was based just on their family history and gender alone. And then we, again, like I mentioned, followed people for a year afterwards. So when we're trying to do this, one of the challenges is how do you communicate about genetics and risk in a complex disorder like Alzheimer's disease? So I just want to, before I get into how we did it in particular, I want to make a few general points about risk communication, because in our world in health education, we see that a lot of times health practitioners don't necessarily use what we would consider best practices in risk communication, even though scores of providers across all different domains are often communicating about risk. So here's just a quick example using our friend the Wolverine here, example of poor risk communication. So let's say you had the hypothetical of women who have the gene variant UM1817 have a 50% increased risk of developing Wolverine syndrome. Well, what would be wrong with something like that? We see these kinds of phrases used in clinical practice or used in media reporting all the time. Well, I think it's important in risk communication to be thinking about things like there's no real time frame given in this risk message. There's no information is given in percentages, even though we know that the average person actually can relate to and understand frequency information better than percentages. This is only relative risk. We're saying 50% increased, but we don't say what's the absolute risk that's associated with this gene. And there's no reference group, 50% increased risk compared to whom. But I think this is important because I think, again, this applies not just to genetic information, but all kinds of risk information. So you might want to be thinking in your practices, are you talking about risk with patients? How are you conveying this? So here would be what we would say might be a better way of doing it. You could incorporate that information I mentioned earlier by saying, in general, women have a 2% or 2 in 100 chance of developing Wolverine syndrome by age 35. Women who carry the UM1817 variant, however, have a 3%, 3 in 100 chance of developing Wolverine syndrome by age 35. And Wolverine syndrome, though, is much milder than Buckeye syndrome, which is a much more severe health problem that I think needs increased public health attention. So we try, I can't say we always followed every single rule, but I think we try to use some of these in our own practice. But when you're talking about genetic information in particular, you also have to think about a couple special issues. This idea of genetic exceptionalism, the idea that people are going to treat, just because of its label as genetic, that information as different and perhaps more powerful than it might otherwise or should be treated. So this idea of exceptionalism is important to keep in mind. When we're talking about susceptibility testing, a lot of times we don't have the ability to integrate the genetic research with other types of research that show environmental or behavioral risk factors. So we don't have a situation, in some diseases you have it, like the Gale model has an integrative model of risk of breast cancer, but a lot of times we really don't know how are these factors additive, interactive, orthogonal. We don't necessarily know. So sometimes that's a challenge to giving precise quantitative information. There's also this notion of second-order uncertainty. So sometimes people can get confused because they're hearing about risk of having a mutation in the first place, and that mutation confers risk of disease. So it's easy for both professionals and patients to get confused about what risk are you talking about. Is it just risk of having this genetic factor versus risk of the disease? And of course, with genetic information, it can have meaning not just for the patient, but also for other family members as well. So you have to think about this communication in a family systems context. So with that as a backdrop, let's talk about how we did this in our study. So I like this schematic because it shows that a lot of people are focused on just the one piece of genetic information, but as I showed earlier, Alzheimer's is a multifactorial disease. So we ended up publishing risk curves that we thought were a valuable ancillary tool for clinicians who might be talking about this. So let's run through this example. So you might use a visual aid like this. So let's say we had a woman who had a parent with Alzheimer's disease, who we also knew she had a 3-4 genotype. Our genetic counselors could use this For example, you can see there's a curve for the general population risk of Alzheimer's disease that goes out to about 10% by age 85. You can see that having that parent with Alzheimer's elevates risk, so that first-degree relative risk is about 30% by age 85. And then on top of the family history, if you add this E4 allele piece of information, you can see risk is elevated further to about 52% by age 85. And again, this kind of tool, you would want to have someone help explain it. You wouldn't just want to give this handout and have the patient walk away. On the other hand, though, it's valuable for a variety of reasons. You can see that a lot of people never get Alzheimer's disease, no matter how long they live. So this idea that E4 is neither necessary nor sufficient, I think is an important one to mention. There's also this idea of, we have a lot of people in our studies who are in their 40s and 50s, they lose their car keys, they're convinced that this is the first sign of Alzheimer's. So it's nice to be able to show the importance of age as well, and as well be able to compare risk across groups. So you might think about visual tools like this, again, whether it's related to genetic testing or not, in terms of ways in which you convey risk to your patients. So how do people make sense of this information? Well, people very much got the idea that they understood very well that genetics did not equate to destiny in this context. The vast majority of our participants, were able to recall, did they have this E4 allele or not? But a lot of people, couldn't recall the exact genotype they had been disclosed and couldn't recall the lifetime risk information. And this was even in a very highly educated group. So I think it shows that we need to be humble, I think, in what we can expect people to really truly internalize and take away, even if we are trying to do our best in terms of education. And sometimes we have to figure out, is just getting the gist of the message good enough? We have to think about situations where just getting the basic take-home message is sufficient versus, well, no, we really want people to have a finer grained understanding of risk, and that may depend on the context and what treatment options might be available, for example. And just one piece of data that I'd like to show that helps demonstrate this idea of genetic exceptionalism that I talked about earlier. So a lot of people were concerned about so-called genetic fatalism. We didn't really see that. So again, this idea that people would have fatalistic views about their chances of developing Alzheimer's if they learned they were E4 positive. We actually found more evidence for the flip side of things, so-called false reassurance. That people actually seem to overrate this idea of being E4 negative, that they didn't have this genetic risk factor, so that they were perhaps more in the clear than perhaps the objective evidence would warrant. So we looked in our first trial, we had, in our intervention arm, people were not disclosed ApoE genotype, or in our control arm, people were not disclosed ApoE genotype, but they got a lifetime risk estimate of 29%. In the intervention arm, they got the same exact lifetime risk estimate, but they also got this added piece of information that they did not have this E4 allele. So we thought it was interesting that even though both are getting the same take-home lifetime risk estimate of Alzheimer's, they had very different subjective perceptions of risk. So you see that in this sub-study, many fewer of the people who got that E4 negative news are saying they will believe they will develop Alzheimer's. In fact, only about 10%, which actually is more in line with the general population risks as opposed to someone with the family history that these people had. And they're much more likely to say that my anxiety is lower about developing Alzheimer's as a result of getting this information, and my personal sense of risk is lower. So good news was they seemed to gain some psychological relief from learning they didn't have the E4 allele. The fear is that they maybe overrate that piece of information. And I think that's particularly going to be important. In Alzheimer's, there's not a lot that's proven that one can do, but you wouldn't want to have this situation, for example, if there are proven means of reducing risk of disease. You don't want people to say, hey, I don't have the genetic risk factor, now I can go out and have a terrible diet or never exercise or never floss my teeth ever again, things like that. We need to think about, that people might react to genetic information in particular ways. In our study, we were also interested in this idea of, is this information going to be psychologically harmful to people? And in fact, the medical community has said we should not be doing ApoE genetic testing at all because it's got limited predictive value and there's no proven means of preventing Alzheimer's disease. So why saddle people with this kind of information? But in fact, we found that in our study, people did not seem to have adverse psychological reactions to this kind of information. So we looked at this a variety of ways, anxiety, depression scales. So you saw that the intervention group was the group that got the ApoE information. We divided that into E4 positive, E4 negative. No matter which way you sliced it, you really saw no changes in anxiety either from baseline or no within-group differences. So that kind of gave us some reassurance that maybe some of these fears that this is going to be psychologically toxic information were perhaps overblown. And again, remember, we did this with a select sample that was volunteering for this information. We had genetic counselors involved. So we don't want the 23andMe's of the world to say, oh, well, now you can just put it on the internet and we'll have the same results. Obviously, you have to think about where does it generalize and not. But I think it did show that if you do this in a controlled context with expert clinicians, that we didn't necessarily see these adverse psychological effects. That's not to say that getting E4 information was completely benign. You see that some people did report a negative impact subjectively or said that it did elevate their anxiety about AD in particular, but you can see that the vast majority of our participants were reporting positive or neutral impact or same or lower anxiety about disease. And so you wouldn't think that this would be huge news, but in the world of ApoE testing, we were able to get this in New England Journal because there was such debate about speculation about the psychological harms of this kind of testing. And our view is a lot of times there's supposition about the benefits and harms of genetic testing, and not a lot of times do we see the clinical trials that actually try to give some empirical evidence to help guide policy, rather than saying we don't want to do this because we fear what might happen. Does genetic testing influence health-related behaviors? Well, there have been some reviews of other work in this area, and I think it kind of depends on the context. So when you have situations like BRCA testing for hereditary breast and ovarian cancer, we see that this information is highly promoting of health behaviors, for example, in terms of surveillance of disease, prophylactic surgeries that might be performed. And that's because you have a high penetrance mutation that you're giving information and you have available treatment options. I think there's probably been some wishful thinking, though, from people in the genomics world that if we just give people genetic risk information for common conditions, that's going to be the magic bullet to get them to exercise more often, to get them to make dietary changes. We don't see a lot of evidence. So in your own practices, I think there's the hope that maybe, I know you deal with trying to promote routine behaviors all the time, and if it's going to be challenging without genetic information, I don't think we can expect that genetic information is going to magically make people more likely to comply with their regimens if it's difficult, complex behavior. I think what we're going to see, though, in the future is that we're going to see a move away from the provision of just single pieces of genetic information. We're going to see genetic information bundled for numerous conditions at once. And I think that will raise some interesting questions about will results be different in that kind of format or not. What we did find in our study was that we saw changes in dietary supplement use. And it was interesting to us because, again, there's no proven means of preventing Alzheimer's disease, but a lot of people have the hope that something, and I think when we were doing our first trial, vitamin E was in the newspapers. There was hope that vitamin E might somehow be preventive. And so we saw that was what people were turning to. And I think we need to think about this for diseases where we might see genetic testing paired with marketing of over-the-counter products that don't require prescriptions, that maybe exploit fears of disease. And so I think with baby boomers moving into older age, we see these unproven products like Focus Factor and Senior Moment, et cetera. And so I don't know if there are equivalents in the dental world, but I think we need to be mindful that people might respond to risk information in these ways that we might not necessarily approve of. I also think it's interesting to consider how when people get genetic information, it may promote their views of a condition as having kind of an essential biological basis as opposed to being modifiable through behavior change. And some of this evidence comes from studies in familial hypercholesterolemia, where they did a randomized trial where they provided just a routine diagnosis versus a diagnosis that was had enhanced by genetic test information. And so the group that got the genetic information actually had changes in their beliefs in terms of how efficacious would it be to lower their cholesterol to reduce their risk of a heart attack. And so the patients, with the mutations were less likely to rate diet as being an effective means, even though there's no evidence that suggests just because you have this genetic mutation, somehow diet's going to be less effective for you. But again, it kind of promoted this view of well, my version must be kind of a more entrenched, biologically caused, impermeable to behavioral changes. So again, thinking about how genetic information might get incorporated into people's illness beliefs and perceptions, I think is important to keep in mind. Another behavioral change that we saw that I think relates to policy issues is we saw that participants in our study who found out they had this E4 allele were more likely to report some kind of long-term care insurance change, which makes sense given that Alzheimer's disease is a main driver of long-term care costs. Now, what's interesting here is you may have heard about or thought about, well, what protections are there in terms of how health insurance companies, how employers might use genetic information. I'm not sure if the other speakers have addressed this yet, but we do have federal laws on the books now. Relatively recently, 2008, President Bush signed the Genetic Information Non-Discrimination Act. So we now have protections at the federal level, and some of these are actually enhanced at the state level with other regulations, that prohibits the use of genetic information by health insurers, for example, to deny coverage or elevate premiums. And it also prohibits the use of genetic information by employers in hiring or firing decisions. So that's the good news. But what GINA does not cover, it does not cover long-term care insurance where we saw some of these behavior changes. It doesn't cover disability or life insurance. So again, to the extent to which genetic information might be used for people to make decisions around these other types of insurance, I think we need to think about, do we need an enhanced policy that goes beyond the basic GINA protections to address this or not? And for those of you who are interested in GINA, there's a very helpful website called ginahelp.org. I teach a genetics class, and last semester I had 2 GINAs in my class, so it was very frustrating that always like their heads would jerk whenever I mentioned this legislation. So anyway, the Genetic Information Non-Discrimination Act, I think, raises a lot of questions for people. And again, given that we might see broader use of genetic testing of all types, I think it behooves us just as general citizens to know what's out there in terms of protection. Now, I think Dr. Ginobili alluded to this idea of genetic testing becoming available outside of the healthcare context. And I think we've seen in recent years, Time magazine in 2008 described the 23andMe retail DNA test as its invention of the year. Steven Pinker did a cover story in the New York Times about my genomic self, his experience learning about his genomes. Sergey Brin, who's the co-founder of Google, actually, and his wife is a co-founder of the 23andMe, he himself learned he was at high risk for Parkinson's disease from a genetic test, and now he's pouring a lot of money into Parkinson's research and advocacy. Again, I don't think we see a lot of this filtering into your world just yet, although we do see some examples of personal genetic tests that have been marketed. But again, it's something to keep an eye on in the future, because I think it really changes the dynamic when people are getting information outside of a formal healthcare context. We don't know, why they might be pursuing it, and they may come to you to help make sense of information if they didn't get it from the website, page that described their risk. And I think this kind of idea of people getting genetic information outside of an encounter with a healthcare professional raises this idea of the distinction between clinical and personal utility. So I think in healthcare we think a lot about, does a test have clinical utility? Does it inform a diagnosis in a meaningful way? Does it inform our selection of treatments? Does it inform screening recommendations that we might have? Does it prompt risk reduction behavior? And there's good reason why we think of clinical utility, and I think people were asking before about whether certain tests would be reimbursed or not. I think we're only going to see tests reimbursed if they have demonstrated clinical utility for the most part. However, this idea of consumer and personal genomics raises this notion that we've seen in our research that people invest a lot of personal utility in genomic information. They see it as useful for increasing their awareness of a range of health and disease risks. So again, we saw a lot of our participants saying, well, I knew I couldn't necessarily act on it right away, but I just want to be kind of more plugged in. I know I have a family history of this problem, so it kind of just makes me feel better that I'm going to stay more on top of the literature, more on top of the latest news, and that awareness is valuable to me. Again, the LTC issue, this idea of insurance planning, people are often thinking about advanced planning from a financial point of view when they're thinking about health risks. There's some people who, as I pointed out, gain psychological relief from knowing they didn't have this risk factor. And so people have psychological reasons for why they may or may not want this kind of information. And a lot of people just, use this cliche of knowledge is a good thing. Knowledge is power. They said, well, it's my genome. I have a right to this information. And why not get this information if it's out there? And so this idea of personal autonomy being a very salient value here, particularly in the U.S., what we heard from a lot of our participants. So we're actually interested ourselves in looking at because this direct-to-consumer stuff has raised a lot of policy concerns about should we be regulating this new industry more. So we actually have just launched a new study where we're going to be following consumers of some of these companies and trying to see, we survey them at baseline before they get information, but after they've signed up for the service, and then we'll be following them over time. Again, with this idea of, there's a lot of people saying, like the country of Germany bans all testing of this type. They just have a blanket ban on any of this. There's some, again, on the proponent side who say this is a new way of thinking about empowering people with information. So there's a lot of ideological polarization, but again, not a lot of data about why do people want this, what are they doing with it, what are the harms, what are the benefits. So we see this as an interesting project in that regard. So hopefully, again, there's some applications on the horizon that I think you heard about from the earlier speakers. So I think this is a field that is starting to become paid more attention to in dentistry. I think that when you think about genetic testing, hopefully some of what I've talked about will help sensitize you to the importance of patient education and particularly risk communication in this context. I think we need to think about the impact of how test results might shape our patients' perceptions of their risk. It may prompt preventive behaviors of certain kinds, but a lot of these behaviors may not necessarily be ones that we are hoping to promote. So to be aware of the different ways in which people might respond to genetic test information. And I think, I've just touched briefly on them, but I hope you realize some of the broader ethical and policy issues that are implicated by providing people this type of information, whether it's around who should have access to this kind of information under what conditions, and again, what do we as a society need to be doing in terms of having policies that might protect against the use of information for discriminatory purposes. So I want to acknowledge our many collaborators across various institutions, particularly at our site. Wendy Ullman is our genetic counselor who's been fabulous. We have a whole team of people across the U.S. that I want to thank for our work with Reveal and related projects. And I will go ahead and stop there, and then are we having a panel or are there individual questions? So I'll stop for now, and thanks for your attention.
So we have a couple of questions for Dr. Roberts on his presentation. So one of the questions, things you mentioned is patient education, and it's said that about a third of the U.S. population is literally health illiterate. Mm-hmm. So now things are going to be upregulated greatly in this particular environment where the sophisticated genetics information has to be transmitted to these patients. Is there any work being done to start thinking about how do we educate such a vast population on this new technology? Because if we don't, we're really creating a tiered system of care again, where some will understand enough to get this, others will not.
Yes, so the question is, it's a challenge just with even more basic information given the wide range of health literacy levels out there. Yeah, I think that's going to be a particular challenge here because just the jargon that you use can be overwhelming even to highly educated people. I think one thing we need to do is, I think, even though I think the traditional genetic counseling model has been valuable in a lot of respects, particularly for diseases like Huntington's or BRCA testing, but I don't think we necessarily need to adopt that model across different types of genetic information. Because if you know anything about genetic counseling, it can often involve kind of a genetics mini lesson. This is a chromosome, and I think people often just want kind of the take-home practical information. So I think we maybe want to be less ambitious about trying to have people understand scientific principles of genetics, although sometimes that can be valuable, and more just streamlining the approach so that you make it more accessible, and sometimes less can be more. I think what's interesting is, even though I'm a critic of these companies in various ways for their approach, because I think sometimes it's maybe leaping ahead too quickly, I think one thing that's been innovative is they've really tried to provide some of this education in a much more engaging way than I think we as traditional health educators have done. So we see a lot of use, for example, of some of these accompanying website videos and kind of using popular examples in a way that I think engages the public. But I think we still suffer from some of the same problems that plague all of patient education, is that when you look at the materials, it's recommended that they should be at 8th grade education level or lower. If you do a textual analysis of a lot of materials, they still end up being way, way too high. And I think that's a real challenge, is how can we make it more accessible but still capture some of the inherent scientific complexity that's involved in these kinds of technologies.
Paul?
Yeah, thank you for a very nice presentation. I don't want to make this question sound like I watch too much of these CSI TV shows, but it is true that 30 years ago we could elute picogram amounts of DNA or plasmid off a piece of paper and sequence it and know all the genes. And while giving blood or something to a physician to analyze our DNA would need some kind of consent, I can imagine that it wouldn't be that difficult to scrape this microphone here and get my epithelial cells and get my whole genome, or get the saliva from licking a stamp, and someone could have this information. And I'm wondering if in fact that would be an act of larceny, and if other things besides these insurance things that you talked about, but there are probably other social issues too that DNA would, and these sequences would be out there, and I'm wondering if people in your field talk about that and think about that as well.
Well, yeah, I think one of the issues, I didn't go into a lot about kind of ethnic minority differences and attitudes towards genetic research, but I think there's been some work to suggest that, even though we can compartmentalize use of genetic information for medical purposes, or for other uses, there is a large FBI CODIS database of DNA samples usually from convicted felons, but in some places you just have to be arrested in order to have a DNA sample taken. So I think that's a potential concern, is that people often, particularly if they have mistrust of public institutions, might wonder, well, what is the government doing with my information? Who's it going to be shared with? So I think there are some public concerns about that. It was interesting, I don't know how many of you follow the fact that we have a newborn screening program nationwide, and different states have tried to use the newborn screening registries as research repositories. So even though it's a public health program, the blood spots they collect for newborn screening can be retained for years, and DNA can still be extracted. And so some states have tried to do this, and the backlash that has erupted has shut down the entire research enterprise. So for example, in Texas, there was a lawsuit that ended up resulting in millions of these blood spots being destroyed. And so there's a similar controversy in Michigan now in terms of, should we be able to try to use blood spots that are originally collected for newborn screening, can we also use them as a research resource? So I don't know if that directly addressed, but I think those are some of these broader social issues that are raised by collection of genetic information that I think have major implications for research and policy.
Just following along that same train of thought, when we're collecting saliva or collecting blood for genetic information, you can obviously analyze it for all sorts of other things. I mean, all the baseball players are worried about, illicit drug use, screening, and whatever. What are the limitations on what a lab can actually analyze a sample for?
Well, I mean, are you talking about the technical or the ethical limitations?
The ethical ones.
Well, I think the ethical limitation should be, outlined in the informed consent usually, and so I think there's been a lot of work trying to be more rigorous in our informed consent approaches, to really elucidating patient preferences about what are they okay with, what are they not okay with. I think it gets tricky sometimes because in some of these major court cases around who owns biological samples, we see that the courts have often decided that it's the institution that ends up owning the sample, once it's actually collected. And sometimes informed consent can be very vague about future uses of samples, what they might be repurposed for. So I think some have argued that we need to be, more upfront in our informed consent about trying to anticipate these future possibilities and getting that consent up front, or at least developing mechanisms and relationships with people so that it's easier to go back or easier to have people opt out at a later date. And again, some people have promoted the idea of if we use some of these web-based approaches for research involvement, that's an easier way for people to be kept up to date, to be contacted about, all right, we got consent for this initial purpose, do you now consent for this future use?
I mean, it would be interesting to know what an individual's anxieties are about the negative use of their information as opposed to the positive use of their information.
Well, I think it can depend on the context. We saw a very celebrated case recently. There was a Native American tribe in Arizona, the Havasupai tribe, that ended up gaining a settlement from Arizona State University because they had biological samples taken for what they thought was going to be diabetes research. They found out later it was being done for schizophrenia research and also some ancestry research, and the ancestry research contradicted their folk beliefs about the origin of the tribe. And so they were very offended by this research and ended up, gaining the samples back from the university. So I think that's just one example that points out the importance of thinking about public trust of this enterprise and trying to develop consent procedures that hopefully avoid those harmful cases. And I think in the newborn screening example, what was problematic for people, they weren't so much concerned that, the government's going to use my DNA and discriminate against me. Oftentimes participants talk about this, it was just a basic respect issue. It was the idea you didn't ask me if it was okay, and then I find out through the news media that this is what my sample is being used for. There was that kind of lack of respect that seemed to really be problematic for certain people.
Other questions? If not, I'd like to invite our speakers up, and I'd like to open this broadly to everybody here, particularly our students.